nursing care of the patient with problems with mobility and problems with the immune system. These are our objectives, so review anatomy and physiology, describe the normal musculoskeletal assessment, describe age-related changes, discuss tests and nursing interventions, recognize diversity issues. We're going to also discuss the etiology and pathophysiology, clinical manifestation, nursing interventions, and collaborative management of strains, sprains, dislocations, bursitis, carpal tunnel, meniscus issues, and muscle spasms, as well as fractures. All right, so this is an illustration of the skeletal system. And so what is the purpose? What's the function of our skeleton? So skeleton is basically a supportive tissue. So it provides structure. It protects our vital organs. It is also used to store minerals, specifically calcium. And it is also the site of hematopoiesis, being the bone marrow. All right, this is an illustration of the different muscles. So this is image of the anterior muscles and then the posterior muscles. You guys don't really have to memorize this, just know that that's how it looks like. Know the three types of muscle. So you have your skeletal, your smooth muscle, and cardiac muscle. So skeletal is pretty straightforward. Those are used for movement. Smooth muscle, typically they're what comprises your different organs and as well as your vessels or vasculature. And then cardiac, well, that's your heart muscle. Please know which ones are the voluntary muscles versus involuntary muscles. So voluntary is basically something that you have to voluntarily move, you have control over, and then involuntary would be the muscles that basically do the job whether you consciously want to move them. And so your voluntary muscle would be your skeletal muscles, right? Because those are the muscles that you need to move purposefully. So kind of like your biceps, triceps, and all those things. Now, the smooth and cardiac muscle, those are involuntary, meaning even if you're sleeping or unconscious, they would continue to work without you really thinking about it or purposely doing it. So your cardiac muscles will continue to work automatically, same thing as your smooth muscles. Now, let's talk about the joints. So your joints, you can classify them based on their structure as well as function. Although that said, it kind of overlaps because they're very similar when you really start thinking about it. So you have by structure, you have fibrous, cartilaginous, and synovial joints. So fibrous will be the type of joints that have little to no movement. So an example of fibrous joint would be the joints in your skull, because you don't want them to move, especially as an adult, right? Because you want them to stay in place to protect your brain. Now your cartilaginous joints, that would be the joints that have some slight movement. So an example of that would be the joints in your rib cage. So you want them to be able to move a little bit to allow for your lung expansion. Now your synovial joints, that would be the freely movable ones. So that would be, example of that would be the joints in your hips, your humerus, right? So that would be considered synovial joints. Now by function, you have synarthrosis, amphiarthrosis, and diarthrosis. So synarthrosis would mean that they're immovable. So these are joints that don't move. And then amphiarthrosis are slightly movable, and then diarthrosis are freely movable. So notice that synovial joints are considered diarthrosis, and then the amphiarthrosis are basically your cartilaginous joints, and then synarthrosis would be your immovable, which would be your fibrous joints. All right, let's talk about age-related changes. So what happens as we age? As you guys know, many of the things fall apart as we age. And so, generally speaking, I'm not saying it always happens to everybody. Now, people's risk factors are going to be different. Lifestyle is a big factor when it comes to this age-related changes. Obviously, the less active, the poorer lifestyle, the more comorbidities, these things can probably happen sooner and faster compared to a person who's a lot healthier, maybe a little bit more active, and who has a very healthy lifestyle. So, but this is just generally speaking. So generally speaking, as we age, our muscle mass decreases by 30 to 40%, thus resulting in a reduced strength. So we become weaker as we age. In addition to that, our movement becomes very limited because of stiffening of our ligaments and tendons. In addition, we also have a more decreased bone density, which basically leads to either osteopenia, and if we don't really take care of it, or if it gets worse, it can lead to osteoporosis. So osteoporosis, right, that would be increased bone loss. It can lead to higher risk for fracture. You will also notice that as we age, we kind of tend to become shorter. And so that's really the result of the breakdown of our inner vertebral disc. So basically, we're losing height. Our discs are flattening, causing us to, again, lose that height and appear shorter, which it's not really just appearing shorter, we're actually shorter. In addition to that, hand and foot movement, the speed, that will decrease. So then that also factors in when it comes to our risk for fall. So when it's harder for us to move, right, we have a higher likelihood of falling or injuring ourselves. One-legged balance also declines. So definitely gait changes. You're going to start noticing gait changes. Our grip strength changes as well. So we become weaker. There's going to be a reduced range of motion, which makes sense, right? Because our tendons, ligaments, our joints become stiff. We tend to develop osteoarthritis as we get older. And definitely when all of these things are affected, right, as our bones, our muscles, our joints are falling apart, eventually it can affect our ability to perform activities of the daily living. So that will include even our basic necessities such as bathing, dressing, feeding ourselves, and stuff like that. So notice that as we age, those are the things that we may struggle with. And definitely one of the highest priority would be fall prevention as we are aging. And we know that once a patient falls, right, they break a hip, that's considered a sentinel event. Usually that leads to another thing, which leads to hospitalization, which potentially can lead to pneumonia and so on. Diagnostic tests. Sometimes the doctors will order different diagnostic tests. Typically, there is a reason why they order specific tests. The most common one that you will see being ordered would be your x-rays. So x-rays in general will help you evaluate bone density, to look at structures. Usually they're used to look if there's any fracture or damage within the bone. Usually there's no special preps or consent needed. It's pretty easy and quick. And typically you have your results depending on where you work, but typically the result can be out as soon as within the next 30 minutes or so, depending on the availability of a radiologist who can actually interpret the results. Now, you can also have a patient who may need to have a CT scan. A CT scan is used to evaluate musculoskeletal trauma. It also allows for basically a better visualization of the different parts of the body, including soft tissue. So it allows visualization of both the hard and soft tissue. So sometimes things that we can't really see on an x-ray, we are going to be able to see that through a CT scan. For this, typically there's no consent needed unless we need a CT with IV contrast. So there needs to be a specific checklist for IV contrast, which also will include a consent for that. Next would be an MRI. So MRI or magnetic resonance imaging would help evaluate for the vasculature. It also is basically a higher definition CT scan. That's how I think about it, because it allows you to again have a better view of the different organs of the bone and muscle structure. And so there are times that we may need an MRI if we want a little bit more detail. So this type of test will help evaluate for avascular necrosis, osteomyelitis, tumors, disc abnormalities, ligament tears. So the tears are really hard to visualize on an, well, typically you can't even see it on an x-ray. So if there's a suspicion for any tear, then they may order an MRI. Now, consent is needed. There's a questionnaire and a checklist to ensure that the patient doesn't have anything metallic in their body, because that can move around. So we don't want that if they have something sharp inside their body. And also, so it requires a checklist. We have to be very careful when we're bringing a patient in an MRI machine. We have to make sure that we, even as healthcare providers, we shouldn't have anything metal in our body, because guess what? It's gonna come out flying. And so again, be very careful. Make sure you're doing the checklist before bringing your patients to an MRI machine. And that's including making sure that the gurney that we use is safe for MRI. We also need to switch our IV pumps. So if we have a regular IV pump, the Alaris pump, that's not MRI safe. So we actually, if we have any drips, we have to switch it to an MRI safe IV pump. So we have to be, again, very careful with that. Another imaging that they may order is a bone scan. So bone scans are used to check for blood supply. It also allows for visualization of tissue death because of the lack of blood supply. There's also the bone density scan, which is used to evaluate the mineral density or the bone density. It's typically used to diagnose osteoporosis or diagnose osteopenia. So just based on the bone density scan. Now, arthroscopy is basically a diagnostic procedure wherein they use arthroscopes or basically little tubes that will allow them to go inside that joint area. So an example of that is in order to examine the knee area, so they can look at the surface of the joint, check underneath it, check at the meniscus, look at the membranes surrounding it, if there's any tissue damage, anything going on, and it allows for fluid drainage. In addition to imaging, we also have patients have some blood work done. So the most common one when it comes to your musculoskeletal system is drawing calcium levels, vitamin D levels, phosphorus, and uric acid. So please remember the normal values of your calcium and phosphorus. Anyhow, so for calcium, the normal that you have to remember is 9 to 11. And so typically calcium is decreased due to malabsorption, lack of calcium intake. So it's usually dietary related. And on the other hand, you may see an increase in bone tumor. So you're going to learn more about this when you go to third semester. Anyway, something that I want you guys to start paying attention is your albumin level whenever your calcium level is low. So know that calcium is typically bound to albumin. And so your calcium level may be affected by your albumin level. So if you have a patient with low albumin, it may appear that the patient has low calcium levels when in fact they don't have low calcium level. It's just hard to measure because they don't have enough albumin to attach to. And so in order to determine, so let's say you have a patient with low albumin and then you have low calcium and you want to determine your the current calcium level of your patient. So it requires you to do some math in order to figure that out. So that's called the corrected calcium. So corrected calcium is basically a formula, a calculation that we do in order to determine our real calcium levels when albumin is low. So corrected calcium is calculated by multiplying 0.8 times whatever normal albumin level is in your hospital, whether it's 4 or 5. So you have to base it on the hospital's normal albumin level minus the patient's albumin level plus the patient's serum calcium level. So whatever number you get, that's called the corrected calcium, and that's likely the patient's true calcium level. So again, not because it's low on the blood results, it's actually low. You have to look at your albumin levels. Anyway, next would be vitamin D. The normal vitamin D level is 30 to 11. Know that most Americans now actually have a very low vitamin D level just because most people actually don't even go out now. So you get your vitamin D through sunshine. I mean, you can supplement, but typically if you like to go outdoor, you go under the sun, it actually helps increase your vitamin D level. So know that vitamin D is very essential in your bone and then calcium absorption. And so make sure that you want to make sure that your patient has enough vitamin D. And again, if they don't have enough vitamin D, you can actually supplement. So normal vitamin D level would be 30 to 100. Next is phosphorus. So phosphorus, the normal is 2.5 to 4.5. Typically, this is decreased due to low intake. Now, it may be increased due to bone tumors as well as kidney disease. Also notice that calcium and phosphorus have an inverse relationship. So sometimes when the calcium is high, your phosphorus will be low, and vice versa. You'll see this most often in your patients in the hospital who have kidney disease. Their phosphorus levels tend to be high. Anyway, next would be uric acid. So your uric acid, the normal levels for male would be 3.5 to 8. And then for female, it's 2.8 to 6.8. This lab test or blood work is typically ordered to diagnose if somebody has gout. So an elevated level of uric acid together with the gout symptoms such as inflammation of the joints, pain in the joints, redness, and so on, can indicate gout. Now, a panic level, a level that's really too high, would be when the uric acid level is greater than 12. Musculoskeletal assessment. So if you get a patient and you have patients with some musculoskeletal issues, it is very important to do a thorough assessment. So your assessment of the patient will include obtaining their health history, right? Or whatever happened, like when did they start having that issue? What makes it worse, what makes it better, what are the interventions that were already implemented, did it work, and so on. In addition to that, we need to visually inspect, right? We have to look at the anatomy, we have to look at the symmetry of those parts of the body, right? Is it the same or does it look different from the left to the right? We also need to palpate, right? So it will allow us to feel for any edema and also tenderness. We need to also look at the range of motion. Does whatever issue it is, does it cause limitation on the range of motion? And again, don't forget your 6 P's. You will see that again on your test. So make sure you remember that. That's really part of your neurovascular assessment. And then cap refill as well as the presence and absence of edema. Right, for your neurovascular assessment cues. So again, always compare the injured area with the symmetric counterpart. So let's say the left side is injured, you want to compare it to the right side, right? Is there any change in colors? Do they look the same or do they look different? Again, your 6 P's, pulses, you want to check for pulses. You want to check for pallor or paleness. Poikilothermia, which is temperature. Paralysis or movement, and then paresthesia if there's any tingling, numbness or tingling, and then pain. So know that this may be indications of nerve and vascular damage, typically arterial damage. And again, look at your capillary refill and the presence of edema.